Okay, let's get started. I know it's spring break in many institutions, schools, etc. So some folks might be away this week. Next slide, please, Rick. So just our usual reminder during our case presentations not to disclose any private health information. Our usual reminders about any assistance that is needed. And is our usual slide about cardio. And today, Danette is going to present about mental health problems and cardiovascular risk and obesity. We've got some commentaries. We have just one case which Danette and Kathleen are going to comment about, and that the case presentation is actually from Kathleen Woods. And these are our disclosure statements. I don't believe there's anything new here. And Danette, the floor is yours. Take it away.
All right. Good morning. So the learning objectives for today are to describe the relationships between anxiety, depression, and other mental health conditions and body weight, describe a minimum of 3 advances in our understanding of psychological causes of obesity, and to describe a minimum of 3 strategies for weight management among patients with serious underlying psychological or psychiatric illness. So this information on this slide I retrieved from the National Alliance on Mental Illness, and it's a well-recognized organization. And so what it says here, basically directly from the website, people with depression have a 40% higher risk of developing cardiovascular and metabolic diseases than the general population. People with serious mental illness have a higher rates of obesity, 41% for men and 50% for women. And people with serious mental illness have twice the rate of type 2 diabetes than the general population. And lastly, people with cardiovascular disease and serious mental illness have a lifespan that is 10 to 20 years shorter than the general population. So research has shown that obesity is linked to attention deficit hyperactivity disorder, mood disorders, anxiety, schizophrenia, binge eating disorder, post-traumatic stress disorder, and substance use disorders. And I'll focus on the top 4 here today. So, how is obesity linked to ADHD? One hypothesis is there's a dysfunction in the dopamine system. So those with disordered eating behaviors and ADHD may have difficulty with impulsivity and difficulty eating in an organized and thoughtful manner. School-age children are less likely to participate in physical activities and organized sports, but more than 50% of children continue to have symptoms in adulthood. So reinforcing behaviors to compensate for low dopamine may include an increase in food consumption, and impulsive eating is a barrier to treatment. So treating adults with medication management for ADHD can help patients to engage in behavior change. And I've actually seen that where, once someone was given the appropriate medication for them, then they were able to focus and they were able to actually follow through with recommendations for given to them by a program. Next slide, please. So how are mood disorders, linked to problems with excess weight? So in our diagnostic manual, the symptoms of mood disorder includes a change in appetite. So that can be increase or decrease. There's changes in energy, sleep, and motivation. And there's also a symptom of impulsivity for those diagnosed with bipolar disorder. So it's thought, that there's a dysregulation in cortisol and chronic low-grade inflammation. And these have been found as mediating factors between weight regulation and depression. Next slide, please. So dysregulation of cortisol in mood disorder is seen as similar, but not as severe as Cushing's syndrome, which is, an increase in cortisol levels over time that it can increase problems with hypertension, bone loss, and even at times problems with type 2 diabetes. So one of the characteristics of this endocrine dysfunction includes excessive visceral fat. And there's also a growing evidence of inflammatory markers and weight gain. And at the end of this presentation, I would like to get some feedback from the registered dietitians here, the experts here, about any anti-inflammatory diets. I would just be curious if that would help to regulate the cortisol. Next slide, please. So the next couple of slides, I got this information from my peers because I had a hard time finding a good up-to-date literature on the medications. So the medications that have been found in real world experiences associated with weight gain is Paxil. They said that's the SSRI that they have found associated with a lot of weight gain. Remeron is very strongly associated with weight gain, and it can be rapid. And my peer said it's rare for someone not to gain lots of weight with it. So Depakote is strongly associated with lots of weight gain, and it can be gradual. Seroquel is associated with weight gain at doses above 150 to 300 milligrams. And olanzapine and clozapine are known for lots of weight gain, and it can be rapid and is very common. And then Abilify, my peers are saying their experiences with it is that it's associated with gradual weight gain and weight gain with Risperdal. It can happen, but it's not very common. Next slide, please. So those medications or psychiatric medications not associated with weight gain include Wellbutrin, mood stabilizer Lamictal, Triliptal and lithium. Latuda is one of the atypical antipsychotics that they found that are least associated with weight gain. And some of the older antipsychotics such as Trilofan and Haldol are not particularly associated with weight gain. Next slide, please. So my peers are mostly psychiatrists, by the way, I probably should have said that. They have found that Topamax and metformin can help. But what they have found, and it should be absolutely no surprise to us, that it's best to have a healthy diet and mostly plants, low carbs, and sticking to complex carbohydrates, whole grains, and vegetables, and staying physically active. Next slide, please. So other factors related to obesity and mental health, I'm going to focus more on depression and anxiety on these next few slides. So appearance satisfaction and body image are very important, in my line of work, and I'll kind of give a little bit more information about that, but just kind of going from this slide here, as appearance satisfaction decreases, depressive symptoms significantly increases for women compared to men. And as body image decreases, or the positive body image, as that decreases, depressive symptoms tend to increase. And an increase in BMI, or as BMI increases, is related to a lower satisfaction with appearance. There is one study that showed that men reported fewer depressive symptoms than women and higher satisfaction with appearance compared to women. So BMI and depressive symptoms have found to be mediated by appearance evaluation. Next slide, please. And there's results from one study, Polish and colleagues, that show that obesity and the perception of being fat significantly increases the likelihood of depression. And the association between obesity and depression is mediated by weight perception. Next slide, please. So in this study by Polish and colleagues, the mediation occurred in participants with partners, non-smokers, non-alcohol abusers, and participants who did not engage in physical activity. And there is evidence that the higher the BMI, the greater the probability of experiencing depression. Next slide. So obesity and appearance-based social anxiety. Well, appearance-based social anxiety is defined as the tension and anxiety one experiences when others evaluate him or her in terms of physical appearance, or just the perception that someone is evaluating him or her. And this could be why I will ask people about exercising and going to a gym. And frequently people tell me that this is a reason why they will not go to a gym, because they are assuming others are evaluating them. The association between BMI and appearance-based social anxiety is mediated by body dissatisfaction, and it's recommended to provide interventions to help improve body image perceptions, to help with weight loss management programs. There's like, in terms of like body image and problems with appearance, sometimes like if you see someone even sitting in your office, you may see them checking their body and touching different areas of their body because they're actually they're judging themselves while they're actually sitting in your office, and it's just not that obvious. Next slide, please. So generally speaking, irregular eating habits are associated with depression and anxiety, body dissatisfaction, a distorted body image perception, unhealthy weight loss methods and diet history, and anxiety disorders are often comorbid with eating disorders. So persons in the obese category overall have higher rates of social anxiety compared to the general population. Next slide, please. So just a brief overview of schizophrenia and obesity. There is some evidence that antipsychotics such as olanzapine can cause increased appetite and lead to binge eating. There's other evidence to show that some antipsychotics have sedative properties, which will lead to a reduced physical activity. Next slide, please. So schizophrenia and obesity, again, there's a literature review that I found that increased weight gain for those diagnosed with schizophrenia can be caused by medications, as we have said, olanzapine and clozapine. They cause rapid weight gain. And so this literature review agrees with my peers' experiences. There's also an increased appetite from some of these medications. There's poor food choices, and a lot of that has also to do with the illness itself. There's loss of self-confidence, sedentary behaviors, and a higher prevalence of metabolic syndrome compared to the general population. But research also shows that metabolic abnormalities predate modern medicine. Next slide, please. So here's three studies, one in England and two in the United States, that I'm going to do an overview of. Next slide, please. Starting with Stepwise. Stepwise is a 12-month program, and the theory is based on behavioral change. And the sessions focus on nutrition and physical activity, the psychological processes underlying weight management, and challenges of living with psychosis and its impact on eating and weight. So this study included 4 2.5-hour weekly group sessions, followed by maintenance sessions at 3 different time points, months 4, 7, and 10. And the intervention also included one-to-one support for 10 minutes every 2 weeks after the intervention period. Next slide, please. So the intervention group and control group, they both included participants with schizophrenia, schizoaffective disorder, and a first episode of psychosis, the races and ethnicities, and both groups included white, Asian, Black, mixed, and other. Next slide, please. So the content, session 1 covered healthier drinks. The next session covered healthier snacks and physical activity, followed by calories and portion sizes and sedentary behaviors. Then, the challenges of eating out and solutions and making choices. And then sessions 5 to 7 were booster sessions to help participants to stick with the program. So this was the analysis was, there was an intent to treat analysis. And so the average weight loss, what they found, it showed there was only like about 0.5 pound. And the schizoaffective group achieved the largest weight reduction of 2.7 pounds. Next slide, please. And so why the study was unsuccessful is thought that there was not enough attention on mental health challenges and medication management. And truthfully, there is a whole, there's a lot of research specifically on this. They're called the CAE studies by Marta Sajatovic, and who actually works at University Hospitals, and Jennifer Levine. And there's not enough attention on mental health challenges and medication management. And for those who lost weight, findings suggest that monitoring and regular feedback from facilitators helped them to succeed. Participants wanted the interventions to be longer than 10 months. Next slide, please. So the ACHIEVE study, it was an 18-month intervention, and it was based on social, cognitive, and behavioral self-management theories that are actually consistent with, rehabilitation principles of skill building and environmental supports. The interventions included lifestyle interventions, which were shown to be effective in the general population. And the study also addressed deficits in memory and executive functioning. And I think the good thing about this is that they divided the information in small chunks, and they repeated the skills that they needed to learn. Next slide, please. So the intervention included group weight management, individual weight management, and group exercises. Next slide, please. In the intervention group and control group, the participants were diagnosed with schizophrenia, schizoaffective, bipolar disorder, major depression, or other. The race or ethnicity were white, Black, Hispanic, or other. Next slide, please. And so there were several sessions offered in this study. It's pretty impressive. So the first 6 months for the weight management sessions, it looks like, if you can see, they attended about half or over half for the first 6 months. And for months 7 to 18, they also attended at least half. So the individual sessions that were offered in the first 6 months, there were 5 of those. And the ones they attended 4 out of 5. And for 7 to 18 months, the attendance significantly decreased here. And if we look at the median group exercise sessions offered for the first 6 months, there were 61 exercise sessions offered, and they attended about 30. But for months 7 to 18, you can see that also significantly decreased. Next slide, please. So the results analysis were conducted according to the intention to treat principle, the same as the previous study. And primary outcomes were changes in weight from randomization at 6 and 18 months. So the net weight change at 6 months was 3.3 pounds, and at 18 months, 7.5 pounds. At 18 months for the intervention group, 63.9% of participants were at or lower than their baseline weight, compared to 49.2% in the control group. And 37.8% of participants in the intervention group lost at least 5% of their baseline weight, compared to 22.7% in the control group. Next slide. So the last study, STRIDE, was a 12-month intervention, and the sessions were 2 hours, 2 hours every week, and included 20 minutes of physical activity delivered over 6 months, followed by 6 monthly maintenance sessions. So the interventions included education about recording foods and beverages and calories consumed, education about recommended servings of fruits, vegetables, and low-fat dairy products, about fiber and fat intake, and about how to record your daily exercise and recording sleep. Next slide, please. So participants were encouraged to do more than 25 minutes of moderate daily physical activity, and other monitoring records were used to assess their progress and to identify barriers to lifestyle change. So if they were doing this along the way, that would be very useful. Participants and interventionists reviewed records and evaluated and modified goals and plans. So yes, they were obviously doing that throughout the study. And they also gave them a Calorie King book and gave them a resistance band to encourage their strength training. Next slide, please. So the intervention and control groups consisted of those diagnosed on the schizophrenia spectrum, bipolar or disorder, or PTSD. And the ethnicities included white, non-white, and Hispanic. Next slide, please. So again, the attention to treat analysis, the intervention group lost 9.7 pounds more than the control participants from baseline to 6 months. And the intervention group lost 5.7 pounds more than controls from baseline to 12 months. And fasting glucose at 12 months, and the intervention decreased, and then the control group increased. Next slide, please. I wanted to put this slide on here because, you know, those 3 studies, even though it's nice to know what those studies include, not everyone has the resources to implement all of those types of interventions. So if you have, let's say in your practice, if you have a NAMI, location near you, you can refer your patients to NAMI because they have complementary health approaches, including exercise and, you know, healthy eating. And there's also, you know, I don't think we talk about this enough. They're called clubhouses. And I have several patients that went to, you know, talked about different clubhouses around Ohio and all the things that they have to offer, and including like support, not only for healthy eating, but support for helping them to learn skills to be able to work, helping them to take their medications while they're there, and just a lot of encouragement with skill building and building up their self-confidence. So there's a lot of good resources that we have, and hopefully you have either a clubhouse or NAMI near your practice you can send your patients to. Next slide, please. And that is it. Thank you.
Thanks, Danette. That's really informative. So before we throw it open, you had a question about anti-inflammatory diets and wanted to hear from some of our folks with some nutritional expertise. Chris, do you want to make any comments? Chris is on.
Yeah, I think there's been a big push, especially through the COVID pandemic, around kind of anti-inflammatory and really kind of pushing that end of the spectrum.
Mm-hmm.
And I think in some ways it's been a little bit exaggerated around the how much eating particular ways to kind of address an immediate immune response versus what a healthy balanced diet will do that supports the immune system, the vitamins and minerals that are involved in supporting the immune system, and our adequate protein we need to maintain that. So I think it's the balance between the healthier eating that allows you to support an immune response and getting a suitable amount of antioxidants in the diet, which comes from that, as compared to a little bit more I think it's one of those areas that's gone a little bit to the, if a little bit is good, a little bit more is better, and we'll address that. I'll be interested to hear what Karen has to say as well.
Thank you.
Well, in general, I think what the research is showing and the evidence, and like Chris says, what is being encouraged is anti-inflammatory type foods, and those appear to be mostly plant-based foods. So a diet that's rich in fruits, vegetables, whole grains, and then minimize, highly saturated fat and processed meats. So the good news is that kind of all goes along with what we already know to be a healthy diet. That, the secret sauce is how to get people to actually do that.
Thank you. Thanks.
Thanks, Karen. Okay, any additional comments or questions for Danette from our group this morning?
So everyone should have a post-clinic survey in your email box. Please take a moment to fill that out to give feedback on today's talk. Next week is our last week of clinic for this spring session. If instead of case studies, we're going to have an open kind of forum, question and answer. If you have any updates from either a fall patient, if you participated in the fall, or a patient that we've discussed this spring, we welcome that as well. If you have anything in advance, if you want to email it to me, that'll help us plan. If not, just come with your questions or your comments.
Yeah, and let me just echo that, these have often been some of the most valuable sessions we've had at ECHO. So if there's unresolved questions or thoughts you have, maybe something you didn't get a chance to comment about, please make sure you make a note of those. And if you are able to send those along in advance, that would help in terms of making sure we have somebody here who can answer them with their expertise. So, all right. Thank you, Claire. Thanks, everyone. Have a wonderful week, and we'll see you next week. Bye-bye.